Good morning, good afternoon, or good evening. I'm Lauren de Mello-Guyot from the London School of Hygiene and Tropical Medicine. And today I'm going to be presenting a study on the effectiveness of hygiene kit distribution to reduce cholera transmission in Kasaï-Oriental, DRC, and this is a prospective cohort study. So our partners for the study were the Ministry of Health in DRC, MSF, UNICEF, and the London School of Hygiene and Tropical Medicine. So, a little bit of an introduction. Annually, there are an estimated 1.3 to 4 million cases of cholera worldwide, resulting in between 21,000 to 143,000 deaths each year. DRC accounts for 5 to 14% of the global cholera burden annually, with 56,000 cholera cases and over 1,000 deaths in 2017 alone. DRC has been experiencing outbreaks of cholera annually since the 1970s, whilst also experiencing multiple humanitarian crises across the country that in turn exacerbate the risk of cholera epidemics. Now, a little bit about cholera. What we know from the evidence is that 80% of cholera transmission is within the household. Household contacts have 100 times greater risk of contracting cholera than those outside of the household. This is partially due, in part, since Vibrio cholerae is hyper-infective in the first 7 to 10 days when you're shedding from a case, and that's in asymptomatic and symptomatic individuals. So what we know is that transmission is predominantly through shared drinking water, shared food, and caring responsibilities of our cholera cases. Now, previous studies have demonstrated that there's been between a 25 to 75% reduction of symptomatic and asymptomatic cholera incidents from different wash interventions. Now, the objectives of our study were to investigate the effectiveness of a hygiene kit distribution combined with health promotion to reduce suspected cholera and self-reported diarrhoea among household contacts of suspected cholera patients admitted to an MSF-supported cholera treatment unit in Kasaï-Oriental, DRC. Now, our study site, Kasaï-Oriental, is in the southern area of DRC, and we were in Kasansa district of the province. In Kasansa district, there are roughly 230,000 people. We had quite limited road access, a low socioeconomic status across the population, and a limited number of healthcare facilities available to that population. It's also seen quite a high burden of cholera in both 2017 and 2018, with numerous outbreaks across those years. The outbreak that we were looking at started on the 9th of August 2018. So we decided on a prospective cohort study. This was in part because it's an emergency response situation and a crisis affected population. This is the study design that we felt best appropriate for that setting. And what this involved is that we enrolled suspected cholera patients and their patient household set at the cholera treatment unit. We then visited their households for baseline data collection within 48 hours of them being admitted. So talking to their house, taking surveys, etc. And then we revisited their house after 7 days. And data was analysed for the association between the hygiene kit and the hygiene kit use and the disease outcomes, as well as the evolution of water and food contamination from enrolment to day 7. Now, our study population data was collected between October 2018 and February 2019. Our study population comprised of 94 suspected cholera cases and their households, which led us to include 444 household contacts. We had less than 10% loss to follow-up, which is reasonable for this study. And household contacts here in this context were defined as individuals sleeping under the same roof or sharing a cooking pot with the suspected cholera case during at least the previous 5 days. And you'll see here on the right, we've got our study flow diagram. So you can see that we did lose some of our study participants along the way of the study and at different stages. Okay, so what was the intervention? Okay, so the intervention was 1 hygiene kit per household, accompanied by wash-related health promotion messages. And this was delivered by community health workers to household contacts of patients on the day of admission. And this is the day of admission to an MSF-supported cholera treatment unit. The hygiene kit itself included a 10-litre hand washing device, so a bucket with tap, a 20-litre jerry can, water treatment products, so either aquatabs or P&G purifier of water, and 1 kilogram of soap. You'll see here in the photos, on the top photo on the right is the community health worker kind of giving a demonstration and explanation to the households of the kit components and how to use it. And on the bottom right, you'll see the components of the hygiene kit for this study. So data collection, we used a mix of quantitative tools and some laboratory work. We did household surveys to look at the wash conditions in the household, and then also assess the uptake and use of the intervention. We collected individual surveys from all of our household contacts. So we wanted to look at who they were and things about them, but also to measure self-reported clinical outcomes, including symptomatic cholera or diarrhea. And then lastly, we took food and water samples. So to measure environmental contamination in both food and water, we did that with the indicator bacteria Enterococcus. So data analysis, for our clinical outcomes, we use log generalized linear models with binomial distribution. And so this was used to estimate the relative risk of household contacts developing suspected cholera or self-reported diarrhea between enrollment and 7-day follow-up. So we're looking at the association of exposure to the intervention, grouped as no kit, low use of the kit, mid use of the kit, and high use of the kit, with the outcomes of suspected cholera and self-reported diarrhea. And we adjusted those for any confounders or effect modifiers. For our environmental outcomes, we use censored Tobit linear regression models, selected because we have a kind of right censoring in our outcome data. So, and this was used to assess the change in coliform density counts of Enterococcus, our indicator bacteria for fecal contamination. And that was again between enrollment and day 7. So let's get to the results. Our household sizes averaged about 8.4 people, which is slightly higher than the average size in DRC, which is roughly around 5 to 5.5. 73.4% of households were in the lowest socioeconomic status category. 86.2% were using unimproved or surface water sources. And average time to and back from those water sources was 66.3 minutes. So 84% of those of those households also used unimproved sanitation, and 4.3% actually used were kind of practicing open defecation. Now, for our clinical outcomes, our analysis showed, our multivariate analysis suggested a statistically significant evidence of a dose-response relationship. So increased kit use was associated with a decreased risk of suspected cholera. So compared to households who had not received a kit, household contacts in the high kit use group had 66% lower incidence of suspected cholera. In the mid-use group, had 53% lower incidence of suspected cholera, and in the low use kit group, they had 22% lower incidence of suspected cholera. Now, for self-reported diarrhea, we didn't see a statistically significant effect on self-reported diarrhea from this intervention, but we did see a very similar dose-response relationship in self-reported diarrhea among the same population, comparable to the cholera outcome. Now, for our environmental outcomes, there was a statistically significant reduction in drinking water contamination among households in receipt of a kit. However, there wasn't a statistically significant effect on food contamination amongst households in receipt of a kit. So what can we say from all of this? So our conclusions are that integration of the hygiene kits at the point of admission of suspected cases is possible. It's both an effective and promising intervention for case-targeted cholera control. From a separate process evaluation that we have also published, we saw a really positive response to the intervention, high use and adherence to hygiene kits by households. However, there were barriers to the timely supply and the timeliness of the response overall. There was inadequate availability of the kit, so consequently there was quite limited coverage of the hygiene kits across the study population or population as a whole. So further work is really required to identify maybe not necessarily the components of the kit and what needs to go in the kit, but actually to improve implementation and the delivery of this quite promising intervention. So there are 2 publications related to this study. The first, of course, is this effectiveness evaluation, which is currently under review and will be published shortly. And the second is the process evaluation, where we looked really at the kind of implementation and delivery of the programme as a whole, and kind of really pieced together some of the successes and challenges of this intervention strategy. So please do feel free to read any of those in addition to watching this presentation. Thank you very much to all of you for watching this video, and thank you very much to the participants of this study and our collaborators in this. I'm really excited to take your questions in the rest of the webinar. Thank you very much.